Can I have my presentation, please? I do receive research grant support from Alcon, so keep in mind. But I'm going to share my views on this customization of this presbyopic solution in real life situation. I'm going to address with IOL only at the moment. But we do recognize the other options we have, like monovision strategies, the traditional multifocal, the trifocals, the low-add multifocal, and so on. And I'm going to address that two main options, the traditional multifocal, like Technis, at least Restore +3, and then in evolution came the low-adds, which improved the distance vision, and intermediate, like Symphony, Restore 2.5, Oculentis, and so on. And now, in the recent time, the trifocals, the Atlisa, the Physiol, Panoptics, and few others. But the key is that we need to have this customization on a scientific basis primarily, but also take into account the patient's profile, his hobby, his profession, his psychology, personality, and so on. So understand the eye profile, and you will learn more about it in presentations to come. So I'm going to take 1, 2, or 3 cases, and this is an 80-year-old lady which otherwise mentally quite okay, with some memory issues as we would expect, and wants to watch television and read. But her problem was that she had a bilateral cataracts, and she was wearing reading glasses for that purpose, not using distance because she was not a very outdoor person, and she would forget where the glasses were. And when she came for the cataract, we found that she was a good candidate on our investigations, that she is a suitable candidate for multifocal. This is a time when we were having a traditional multifocal and low-adds multifocal lenses. So we decided to use the traditional multifocal, but warned her that you will need additional light or little extra light, because these multifocal reduce the contrast sensitivity while reading, and so and she said that's okay, my children will take care of that. So we decided to put +3, but you could have gone for Technis or any other. That's quite all right. And then we realized that she was very happy because she didn't have to remember, and she could read very well. And this helped because the traditional multifocal has an advantage, that they have a really good quality reading vision. They may have many other problems, some intermediate visions or halos and glare, but the positive part of it is that they have a decent reading vision, and therefore it suited this old lady, but make sure that the eye is suitable for it, and age is not an issue with that. Second case has a younger person, and those who are not familiar, we all have many younger patients coming up now in recent years with cataract, God knows why, but this is one of the typical case, an engineer, bilateral cataracts, and wearing -1.5 already before the cataract, and even with now. And this family had young cataracts. Now, on examination, we found he had a PSC cataract, and aberrometry, as you saw in the earlier presentation, had no angle alpha value more than 4, and we thought it was suitable because of the ocular surface and all other checkup. It was suitable for the multifocal. Now, the problem is that young men, they want to see everywhere, they want to do everything. No, but no more glasses, sir, please. And they are driving the cars, motorcycles, and they want to do computer, they want to do everything. So we had to have a binocular strategy, and at that time we had this, which we found very useful, with one eye, which is a dominant eye, which will have a distance vision and also intermediate vision, because we found and we realized that 80% of our population, be it in the USA or in this part of the world, use distance and intermediate vision more of their 80% of the time of their wake-up time. So we thought this would be the right thing for dominant eye, putting low-ad multifocal, giving a very good quality distance vision and sufficient intermediate vision at about 50 or 60 centimeters. So we decided to do that, and then after 2 to 4 weeks' time, we put a traditional multifocal in non-dominant eye, giving a reading vision. And we discussed that preoperatively, that when you use both eyes, you will be fine, but never do that, never compare each eye, never look into the light, because many patients come after the surgery that I see, when I look at this light, I see halos. But did you look at this light earlier before the surgery? Never. So why you want to look at and test yourself for these little things which could be there? So we counsel them not to compare, not to look into the light, and please be patient and wait a month after the second eye is done, and you would still need selectively for some activities use of glasses, so be prepared. So we did that blending with that, and with that additional reading from the traditional, we had a full range from near 30 centimeter, 35 centimeter to distance. So I think that strategy can be useful for this kind of problems that the patients may have, and younger ones and particularly males, are quite not easy, because the ladies are very kind. They will be happy as long as they can do their makeups. So males are more demanding. So you can consider that strategy. And as expected, their unaided performance was quite good, 6.6 because of the Restore 2.5 in one eye. Intermediate was good because of the same low ad, 50, 60 centimeters typical distance, and near the traditional multifocal helped. So that's okay. And they needed one eye 1.25 eye with the low ad whenever they had a demanding near vision. So it's practically a good thing. And only thing, other thing is that because this guy was wearing minus 1.25 or 5 and the myopic, the distance for the near would be different. So teach them beforehand. They don't expect it to read the distance you were handling before. Your distance will change. So if you prepare them well, they are okay, as this patient was, and he had no glare. Although I was expecting, even with one eye traditional, many patients do have. But if you prepare them well, the neurosensory adaptation is really is magic. So be aware of the young people, male patients that are difficult to please. Myopes need to be told about the new reading distance that they would need to get used to it. This case is another youngish person, physician, bilateral cataracts, has a fairly active medical practice, and he is already using progressive glasses for last 12, 15 years. He likes to read, which I'm surprised, because most of the doctors are so tired they don't read these days, certainly not the journals. But he goes on the weekends in the clubs and plays cards, and he always drives in the city. And if you're driving in Delhi or Gurgaon, you don't have to worry because you don't have a speed. So glare is never an issue. You're too close to the other car. But if you're driving in a good city where there's less traffic, that can be an issue. And he said, you know, if you can, I would love to have no glasses here. And we learned from our experience of the traditional multifocals, and that we need to go through the drill of the ocular profile. We need to have sufficient counseling and use of good light when you read, because he was a reader, and be prepared for occasional halos, but you then still will be able to handle it if you are prepared to accept this. And we decided to go for binocular panoptics, which is a relatively later addition on the trifocal lenses. In general, trifocal lenses are very good because they try to address all the three distances. some lenses have a distance at about 70 to 80, and the PanOptix has about 60. So depending upon the activity, you can do that. If you're in a kitchen or a chef or something, you need a long hand and long distance, you would go for a trifocal which has a 70 to 80, like at Lisa or Physiol. But most of the persons in this part of the world with not very long hands and mobile and computers would go for a 60 centimeter, which PanOptix addresses very well. But whatever that is, you can address that, and we could do that with PanOptix with this patient. And he did mention that he does notice halos at night, but it's not bothersome, and I'm ready to accept it. And he managed it quite well in a few weeks' time in the post-operative period. So I think there is a compromise. We must not give an impression to the patients that you will get everything. You have to pay the price if you really want to depend less on the glasses and still have a good quality of vision. That good quality will depend on his profession, his demand, and his fastidiousness or otherwise. But if you are motivated to accept that, this is very good, and it will improve your lifestyle and really will produce that happy patients for us and customization. But it needs a lot of chair time, and counseling is the key word these days for anything, but including if you really want to achieve a refractive target to your satisfaction. So it's a pleasure to invite Dr. Ramamurthy, who is, I think, number one in the experience on multifocal lenses. And before the array or whatever, I don't even remember. I was a kid when he started putting multifocal lenses. So tell us how you deal with those unhappy patients. Thank you.
Thank you so much, Dr. Abhay. Truly grateful to the First Family in Cataract Surgery for repeatedly including me in your wonderful symposium. I deem it an honor. So my premise is to deal with unhappy post-operative patients. These are my financial disclosures, and some of the products I'll be discussing are manufactured by these two companies. I think the most important aspect is to preoperative counseling. Whenever a patient comes to me for a premium intraocular lens, whether it's multifocal or torics, the points we want to drive home is that we are not promising total spectacle independence, but relative independence from glasses. And dysphotopsia is the price they pay. You buy vision for all distances using the currency of contrast. Usually recommend bilateral surgery because once the new occipital cortex is getting similar impulses, it seems to adapt much better. And a secondary touch-up procedure may be needed, and adequate time has to be given for neural adaptation. So once you have spent this time explaining this to your patients preoperatively, most often it's easier to deal with them post-operatively, not that they don't come up with problems. And when they come up with problems, these are the 5 C's. The last C, crazy patient, is what I thought was most common, but now I realize that once you are perioperatively, intraoperatively, and postoperatively dealing with all the other 5 C's, your incidence of dissatisfaction does come down significantly. It was in our inability to understand the problems that the patient is presenting with that used to make us label many of us patients as difficult patients, crazy patients who are complaining, who are difficult to satisfy. So as far as if you are talking about premium intraocular lenses, it's extremely important to hit the target right. There have been speakers have elucidated how you can achieve that. But just in case you are unable to do it, there are several different options. Limbal relaxing incision was something I used to do for quite some time. But almost 10 years back, I gave it up simply because I thought these are inaccurate. The results do subside with time. But now with the availability of digital overlays, I once again have started doing this. It is not refractive accuracy, but what you are able to do is to debulk the amount of anterior corneal astigmatism that these patients have, and especially when you are combining this with multifocal intraocular lenses, it does help. And in case the patient presents with a problem with a residual refractive error, we often offer a LASIK or a transepithelial PRK free of cost, and this is something which is explained to the patient even prior to the first surgery. You can see those intraocular lenses shining over there. Once you have addressed the residual refractive error, it's not just the need for glasses that goes away, but we also find that the problems at dysphotopsia also subsides quite significantly. So it's usually 3 months subsequent to the initial surgery. Once the refractive error has stabilized, wound is quite stable, we go ahead and do this procedure. And just in case we are faced with a large residual error, especially if it's a hyperopic error, which is not amenable to treatment on the cornea, then it's a piggyback lens which comes into our rescue. And it's a large 14 millimeter overall diameter, 6.5 millimeter optic lens, which is gently slid into the sulcus. You can see there is already a YAG capsulotometer there, and this lens, once you place this, you are able to achieve good refractive outcomes. And now toric versions, multifocal versions of this is also available from Indian companies, which makes it quite affordable, and they also seem to work quite well. And in case you have had a large refractive surprise and you feel that it's basically an error in the power of the intraocular lens that has been calculated, that can happen sometimes when you're doing these surgeries in post-refractive surgery scenario. I just wanted to cut short the video. Then IOL exchange is what we do, where we cut the lens by a quarter and then explant the lens and implant the lens of the right power. And if it's a hydrophobic acrylic, the faster you do it, the better. And in case you have a toric intraocular lens that's been implanted and there is a suboptimal outcome, then all you need to do is to go in with the irrigation cannula and gently nudge the lens into the right place. If the residual refractive error, the spherical equivalent is almost zero, that is if you have a -1 with +2 diopters of astigmatism, this is the situation where repositioning of these toric intraocular lenses is going to help. There's no viscoelastic that's used. It's a 2-minute procedure, and you are very often able to optimize the kind of results that these patients have. Needless to say, if you have an opaque capsule, you need to open that up. But more importantly, when you have a multifocal intraocular lens, this is bilateral implantation, 2 eyes of the same patient, you can see the diaphanous thickening that is happening there. And the quality of vision will significantly deteriorate even with this. Having waited for about 3 to 4 months, if the patient has complaints and you think dysphotopsia is not the problem, lens exchange may not be necessary, then I would go ahead and YAG this, create about a 3 millimeter opening right in the center. Decentered lenses is something that's not understood very often, but is extremely important. Again, bilateral implantation. You can see here the lens is extremely well centered by the diffractive rings, and here is decentered. It may be because there is not a good capsulorhexis overlap, or it can be also because of a large angle alpha. I think subsequently this will be dealt with, and that's the reason anywhere when the angle alpha is more than 0.7, I desist from implanting these multifocal intraocular lenses. You can, in case it's a suboptimal implantation of the intraocular lens, you can do a surgical recentration. Laser hydroplasty has been talked about. Does work. I've just done in a couple of patients. Too much pigment dispersal, too much pain for the patient. So this is something that I would not recommend, but it's obviously prevention is the best cure. This is again a problem that we sometimes face. Everything has gone perfectly. You can see a toric intraocular lens done by one of my colleagues in my own center, excellent surgeon, a lawyer by profession, this patient, and had very difficult negative dysphotopsia. And in these cases, bringing the optic out of the capsular bag is one of the options that's offered. But in this case, because the toric intraocular lens and the refractive error was absolutely emmetropia, I did not want to disturb the lens. So in these cases, again, putting in a sulcus lens, you can see this sulcoflex lens that's going in, is a good idea. Because it has a rounded optics, it has a large 6.5 millimeter optic, it seems to work quite well. Again, I just fast forward it a little, and that's the intraocular lens being, it is a 0 power lens, purely implanted for dealing with the negative dysphotopsia. And you find that I have done it in 3 cases so far. And all these patients on post-operative day 1, they report immediate recovery. And of course, this comes at an expense, but it is something that's worth doing in case the patient is significantly troubled by this. This is what you see in the slit lamp and in the anterior segment OCT. You can see the double implant that is over there. And then, of course, dry eye. I'm going to quickly pass over this because this is something all of us know. I think the most important thing I want to recommend is when you are talking about dryness, it's most often the dryness that you have induced because of your medication. So I think post-operative medication, I strongly believe less is more. And today, It's most often lubricants. That's the most important aspect of my medication. Just 2 weeks of steroids, then subsequently just twice a day non-steroidal anti-inflammatory drugs, and I find that the incidence of these problems is less. And of course, if you have a patient with a suboptimal ocular surface, I would deal with this preoperatively before going ahead with the surgery. And then in case you have doing an OCT has become a norm, not just for premium intraocular lenses, but all cases who present for cataract surgery in our center. The incidence of epiretinal membrane is almost 7% in patients above 60 years of age. And these are the common problems that an anterior segment surgeon could easily miss. And obviously, if the patient has these diseases, then you have to avoid a multifocal or even a toric intraocular lens. But sometimes if you notice them post-operatively, they have to be dealt with in an appropriate manner. The patients sometimes complain of a DYSPHOTOPSIA, but they are completely happy with vision all distances. I have this simple -2 diopter glasses with me. I tell the patients that if you are very much disturbed, I'll take your lenses out and put a monofocal lens.